Hello, everyone, and welcome to the Master of Public Health Online Program's Faculty Spotlight webinar with Dr. Laura Ferguson, presented by the Keck School of Medicine at the University of Southern California. My name is Kiana Carter. I am an enrollment advisor for the Master of Public Health Online Program, and I'd like to thank you for taking time out of your busy schedule to join us today. Before we begin, I'd like to review what you can expect during the presentation. To cut down on background noise, please mute your phone lines so as not to disturb the presenters. If you have any questions for our speaker, please type them into the Q&A box in the lower right-hand corner of your screen and hit send. Feel free to enter your questions as you think of them, and we'll answer as many as time allows at the end of the presentation. A copy of this presentation will also be available shortly after. Now here's a quick look at what we'll be covering. First, we will hear from our program director, Dr. Shubha Kumar, who will talk about her background and share some information on the Keck School of Medicine of USC. Then we will hear from one of our students, William Jardell, who will introduce our speaker, Dr. Laura Ferguson. Lastly, we will end the presentation with a brief Q&A session. Again, ask your questions, type them in the Q&A box, and we will answer as many as time allows. Now, let's begin. Hello, Dr. Kumar.
Hi, thank you, Kiana, and thank you everyone for being here today. I'm very happy to be presenting this webinar with Dr. Ferguson, who I work with here at USC in the Department of Preventive Medicine, as well as with the Institute on Inequalities in Global Health. A little bit about my background. So my background is also in global health, like Dr. Ferguson's, and I did my MPH and my PhD looking at really management issues in the global health context and how NGOs are managed, as well as how financing flows, accountability issues in global health, and really kind of that aspect of monitoring and evaluation of programs. That's really my background. I used to work primarily in the NGO world before academia, and that's where a lot of my research as well sits. In terms of the Keck School of Medicine at USC, we were actually established in 1885. We're the oldest medical school in Southern California, and the university itself was established in 1880, so we are over 100 years old, and a dynamic place for activity in terms of research, patient care, education. We have several institutes and centers leading research, whether it's clinical translational science, it's global health, it's epidemiology, and all kinds of matters central to public health. And within our Department of Preventive Medicine, we have over 100 faculty who are doing research within disease prevention, bioinformatics, biostatistics, epidemiology, cancer, environmental health, health behavior, and many other topics. And many of these folks teach in the MPH program, both on campus and online. So that's a little bit of background about USC and about our program. At this point, I'd like to actually turn it over to Will Jardell. Will is one of our fantastic students in the online MPH program, and he is also the student ambassador for the Master of Public Health Student Association group on campus. He is the online student ambassador. And, it's really great because we've had a lot of engagement and interaction with our students online. And this particular initiative, this faculty series webinar, is driven by our students. They were the ones who came up with the idea of really wanting to hear more about what our faculty are doing, what kind of research topics they're engaged in, and just understand what's going on in the world of public health in an informal way. And so this initiative was really driven by the students. Now I'd like to turn it over to Will.
Hi, everyone. I'm excited to introduce Dr. Laura Ferguson today for a talk on mixed methods evaluation, pitfalls and promises in the real world. She is an assistant professor of preventive medicine at the University of Southern California and the director of the program on global health and human rights at the USC Institute on Inequalities in Global Health. Her research focuses on understanding and addressing health system and societal factors affecting the uptake of health services and developing the evidence base of how attention to human rights can improve health outcomes. She collaborates with a range of United Nations agencies, as well as foundations, universities, and non-governmental organizations in different countries. She has spent extended periods of time in low-income countries, primarily sub-Saharan Africa, collaborating with partners, helping to build the capacity of her local colleagues, and designing and managing research and projects to tackle a range of issues, including HIV and AIDS, sexual and reproductive health, and child health. Please join me in welcoming Dr. Laura Ferguson.
Hi everyone, and thanks Will for that introduction. So I'm going to talk today about mixed methods evaluation. But before I really jump into the substance, I'll give you a little background as to sort of who I am and why I want to talk about this. My background, really, I started off working for nonprofits, first in Central America actually, but quite soon after that I moved to sub-Saharan Africa, and was really involved in community-based health in those places until I realized I actually didn't know anything about health at all. So I decided to go to grad school. And I really thought I'd go straight back to Africa after that. But I got a little bit involved in advising around global policy for the United Nations system. And that sort of captured my interest. So I did that for a few years before doing my PhD. And that then obviously brought me into a research space and an academic setting. And what I try and do in this role is that I work still doing the advising to the UN system, to the World Health Organization, UNAIDS, UN Development Program, and others. But I also still work with nonprofits, and I find it really beneficial to have a foot in both of those worlds, because the nonprofits keep me tied into the real world and what's actually happening. And those seem like really important lessons to feed into people who are making decisions around global policies. And then I can bring whatever global policy decisions are occurring back down to the grassroots and make sure that they're appropriate for implementation and follow up on that. So I'm very much in an applied research space where I work with this different range of partners to try and make sure that lessons we're learning are being applied appropriately in both of these different spaces. In terms of mixed methods research, I have to say I think I'm a qualitative researcher at heart still, but when I had what I felt was my first really good research idea, and that was when I was living in Kenya, and I said to the folks running the health system there that they were testing all pregnant women for HIV and diagnosing lots of women, but I could see that they weren't turning up to the HIV clinic. So all these people were being diagnosed with HIV, but then disappearing from the system. And so I said to them that this isn't great, right? You're diagnosing people because you want them in treatment. Let me do a study to figure out why they're not turning up. And they wouldn't let me do it because they didn't believe it was a problem. So I had to redesign the study and first do some quantitative research to make them see that it actually was a problem. And then as soon as I could do that, they're like, wow, that's really interesting. That's a real problem. Can you find out why? So I could then do the study that I wanted to do. And so all that to say really like that different types of data answer different questions and speak to different people. And it seemed really important in trying to affect change in the world to be able to play in both of those spaces and to bring them together in ways that are appropriate for speaking to the different audiences that you have to work with to do this work. And really, it's about becoming sufficiently well-versed in both quantitative and qualitative that you understand how they fit together and that you can supervise teams to do that kind of work. So I don't want to stay in the abstract today, even though I love talking about methods. Most people don't quite as much as I do. So what I wanted to do was to frame it around a study that I'm running in the Gambia. And this is a mixed methods research study, and so I'm going to talk you through why we chose the methodologies that we did, what we actually did. I'll mention some of the findings, but really I'm doing all of this to illustrate why I think that mixed methods work is important, and how it matters. I pressed the wrong button. There we go. So the project that I'm going to talk about the project itself is called Improving Maternal and Child Nutrition and Health in the Gambia. And I'm going to talk about the study design for the evaluation of this project. Just to give a little bit of background, this is a map of the Gambia, which is on the coast of West Africa. The project itself is about maternal and child health and nutrition. It started in right at the beginning of 2015, following a pilot test a little bit earlier. It's funded by the World Bank and implemented by the government, and they're implementing in 3 out of the 7 health regions in the country. And these regions were chosen because they have poorest health and nutrition indicators. And so it was felt that we could have most impact in these areas. And we're actually covering 1/3 of the population of the Gambia, so that's about 600,000 people. So as you can see, it's a small country, and yet covering 600,000 people with an intervention still feels like quite a large undertaking. But as I said, I'm not involved in implementing the project. The World Bank gives money to the government of the Gambia, specifically the Ministry of Health and the National Nutrition Agency, and they implement. All I'm doing is trying to fit a study around what they're doing so I could tell them at the end of the day if it's had the desired impact or not. So the overall impact is they want to improve maternal and child nutrition and health, but the goal of the project, so bringing things down a little bit, is to increase the utilization of community nutrition and primary maternal and child health services in selected regions in the Gambia. Okay? So that's what it is that the government has said that they want to do through this work. The question that I was then given was, well, how would you measure this? Okay? Now, before we can answer that, we need to look a little bit more at the project and say, okay, well, what are they actually doing before we can decide whether or not they're being successful. And so here's an overview of the project itself. It's quite a complex project, and so I'm keeping this at fairly high level, just general intervention information. I'm really happy to go into the details in the Q&A if you want, but right now I just want to give you enough context that you can understand the study design around it. So this project is a results-based financing project, and for those of you who aren't familiar, traditionally, health systems are financed by, every health facility, if you like, is given a budget and told to go and deliver services. Results-based financing flips that on its head a little bit and says, go and deliver services and show us that you're meeting targets for certain services, and then we'll give you money as a reward for having done that. So the more services you deliver, the more money you get. And there is an aspect of quality measurement in there as well, so that we don't totally lose that within this. So that's actually the intervention 2 on this slide, the supply side. So the delivery of selected primary healthcare services is incentivized through results-based financing or performance-based financing within the health facility. So health facilities where this intervention is taking place are getting extra money for the delivery of these selected health services. Intervention 1 is on the demand side because, as we know in public health, even if the services are there, if people don't want to access them, they won't. And so we decided that it was important to incentivize demand for services. And so that's done by 2 things. There's a community results-based financing component through which groups within the community get incentives for them carrying out health education activities, for them referring people to health facilities. There's a whole series of behaviors for which they're then given money, as long as they can show how many people they've referred and all of that kind of stuff, they get subsidized for that. And there's a conditional cash transfer for pregnant women. So pregnant women who show up for antenatal care within the first trimester will get given a payment. If they turn up for another 3 routine antenatal care visits, they'll get another payment. So this is really about asking people to behave in a certain way on the promise that if they do, they will get financial recompense for it. And that's the entire project. So it's really about how do you change people's behavior within the community and within the health facility by giving them financial incentives. So I'm a big believer in theory and in conceptual frameworks. So what I wanted to know is if we do these interventions here, what chain of events do we set in motion that's actually going to lead to improved health outcomes at the end of it? So we created a conceptual framework for the project. We're not the first people to try and improve maternal and child nutrition and health. We're not the first people to implement results-based financing. So we wanted to figure out what can we learn from previous projects about how these things are meant to work. This is a super complicated slide, and we don't need to go into all of the details, but what we tried to do here was to say, if we do some of the things on the left there, the organizational changes and the behavioral changes, what are the pathways that will lead us to improved health outcomes? And we've tried to sketch some of them out on this slide. And I'm not going to go through it all, but I think it's really important to highlight because we need to understand the mechanisms through which we think our projects are going to work. And this will help us when we come to measuring and evaluating them, and I'll come back to that in a bit. So this was our conceptual framework for the supply-side intervention. We had another conceptual framework here for what the work that was being done in communities that basically serves the same purpose of if we implement our set of interventions, through what pathways will that improve uptake of services? So I'm not going to dwell on that hugely. I just think that's important to have for any project that you're doing, or even any research study. It's about having your hypothesis and your hypothesized pathways of change. So here are the list of indicators that the World Bank prioritized for this project. They decided, look, if the goal, remember the goal is to increase the uptake of maternal and child nutrition and health services, this is how they want to measure that. They want to know that there's an increase in the percentage of children aged 0 to 6 months who are exclusively breastfed. They want the number of deliveries attended by certified midwives to increase. They want the number of children who are appropriately supplemented with vitamin A to increase. They want more women using modern methods of family planning. And the last indicator, which I'm going to just put this out there and be super honest, like I don't think is very useful at all, is something that the World Bank has in all of their projects because they're trying to measure how many people they reach through the funding that they give. But from an evaluation perspective, I don't think it helps, but important to understand that donors sometimes have these things in there that we go along with. Okay, so this is what we're trying to measure. Then let's look at what the study design was. Again, it's a complex study design. We did a 2-by-2 phased-in randomized control trial. So what that means is, first of all, important word, it's randomized. So we randomly assigned health facilities and communities to intervention groups and control groups. But we did this in a phased-in way so that by the end of the project period, everybody had received the intervention. But the way that we phased it in created these 4 comparison groups that you can see in the little table here, A, B, C, and D, where A is a pure control group, where they don't have either the demand side or the supply side intervention going on. B shows communities that receive the demand side intervention, but they're not in catchment areas of health facilities with supply side interventions. Conversely, C shows that there are health facilities where intervention is occurring, but communities around them that do not have the demand-side intervention. And then finally, D are places that have both the demand-side and the supply-side intervention. This was really important for us because we had hypothesized that if you do the supply side on its own, you might have some impact. If you do the demand side on its own, you might have some impact. But if you can do them together, that's probably where you're going to have most impact. So we needed to be able to quantify that in our study findings. That was how we chose this design. Seems to be going the wrong way. Let's try again. There we go. So we included, there are 24 health facilities in these 3 regions and 2 intervention communities and 2 control communities per health facility. Remember I said that we randomized? This literally meant that we went out into communities and held lotteries where everybody was present so everybody could see that this was a random assignment. And that was how we determined when the different facilities and communities would enter into the intervention. This again just shows our timeline for data collection, and this is just on the supply side. But you can see the orange boxes is when that's when the intervention begins in these different facilities. And we have some evaluation before anything. We have a midline evaluation, which helps us capture a time when half of the facilities had an intervention and half didn't, and then by the end line, everybody has the intervention. So again, that's when I talked about the phased-in nature of the study. That's really what that reflects. Okay, let's get to methods a little bit. And that is not the methods slide. Hang on. Yep. The order of these has got a little bit confused, but I'll jump around. I can do this. Okay. I want to start with the quantitative data collection. And you can see on the left, there's some household data listed and some community data, but there are, I believe, 7 different questionnaires there. Each of these is administered at baseline, at midline, and at endline. And you can see the sample size there from baseline and midline. The household questionnaire is a huge sample of over 2,000 households each round. The other questionnaires are all much smaller. And a question that comes out a lot is why on earth do you need 7 different questionnaires to evaluate a single project? And the reason that we wanted to do this is that each of these captures the perspectives of different people. In the households, we were talking to women who used health services, or maybe they didn't use health services, but they were women who had been pregnant or delivered recently. And so we wanted to know about their experiences and decisions. Then we talked to health facility managers, and we also did some direct observation of what stuff looked like in health facilities. We talked to individual health workers about their motivations on the project. We did exit questionnaires for clients who had just attended antenatal and child health services to really see what just happened in that consultation that you were just at. And then we talked to folks in the community, so village development committees and village support groups, which are kind of responsible for health education in the communities. The idea was we wanted to get loads of different perspectives so we could try and piece together what it is that was actually happening. And just to take a step back for a minute, I wanted to say something about the logistics of this. This really is large-scale work. My team in the Gambia was, I think I had slightly over 100 people involved in the quantitative data collection. And I have an analysis team of about 5 or 6 statisticians who are all around the world who are helping crunch these numbers. So coming back to the fact that I do mixed method, I could not crunch all of these numbers, and I certainly couldn't collect all of the data, but I know enough about the methodologies and can train all of these people that they can then do the day-to-day to make this. So that's the quantitative piece of this. Then there's the qualitative piece, which we did alongside. Again, you can see on the left all of these different groups of people that we talked to, and we did a mix of focus group discussions and key informant interviews. Another question is, well, why do that? Why do some focus groups and some interviews? Well, different topics and different respondents fit better with one or other of these. So, for example, we did focus group discussions with women, again, women who just had kids, to find out about community norms about childbearing, about general experiences of having children, seeking care within their communities. But then separately, we did individual interviews with what we're calling vulnerable women. And these are women who are, for example, adolescents who've just had children, or widows, or people out of wedlock. So they're generally more marginalized. They're the kind of people who are not going to speak up in a group setting, but we still really want their perspectives because they're a constituency that we're trying to reach. So that's kind of one of the factors that goes into figuring out the methodology that we use even within the qualitative space to collect data. And again, really trying to max out the number of different perspectives that we could get on all of these issues. Again, I've got a whole team working on this, about 5 or 6 local researchers in the Gambia who did a lot of the data collection, and then a team of about 8 or 10 analysts who are working with me on the data analysis. Okay, so in terms of data analysis, again, I don't want to go into this hugely in depth, but just so you understand roughly the overall approach to analysis for both quantitative and qualitative. The quantitative is based essentially on multivariable linear regression models. And again, I'm really happy to go into the nuts and bolts of that if there's quantoid people here who want to do that. But for now, that's, I think, enough to know. And the qualitative, we transcribed all of our interviews and focus groups and coded those data based on a code tree that was initially derived from the literature and from our conceptual frameworks that I showed you earlier. So we were really looking to see if people had anything to say about the pathways we were hypothesizing. But as people talked about other random things as well, we added in those codes so that we didn't lose any of the data that we were getting. Okay, so this was back to the main project indicators as per the World Bank priorities. Just to show how they set things up, there's the indicator shown, the unit of measurement, a baseline value is given of what things are at the very beginning of the project, and then all of these targets for what they want to happen over the 5-year lifespan of the project. And again, this is guiding for us as to we need to make sure that we're capturing this type of information in our study. So this kind of small and confusing slide is a screenshot I took actually earlier today. We set up our questionnaires in Excel and just look at the number of tabs. This is from the household questionnaire. And you can see all the questions running along the top of the spreadsheet and the many more columns in this tab alone. And then you see the number of tabs, which I think got up to about 18 or 19 in the end. This is a huge questionnaire. And remember that this is only one, there's 6 other questionnaires as well. So again, just to note the scale of it and also the detail in terms of having to provide the different response options and skip patterns, and this kind of big questionnaire is kind of a huge attention to detail process. And again, to take a step back on the logistics, we actually administered the questionnaires using tablets, which may sound super logical for here, but no one had ever done that in the Gambia before. So first of all, we had to train everybody on how to use a tablet. Then we had to deal with issues of connectivity because there's really not good internet coverage in some places, so how are we going to do that? We contracted a company in Vietnam to host all of the data in the cloud and do data checks and stuff like that. So imagine now we're working across this range of time zones from the Gambia through here Vietnam, and actually my co-PI is in India. So we were kind of working around the clock in weirdly efficient ways as data were coming in. So we had like real-time data checks going on. But I just wanted to give you a sense of what the questionnaire looked like. Okay. So here are a few of our findings. And again, like I don't want to spend a ton of time on this, but I do think it's important to look at different arms of the study and what we could tell. So I'm going to talk you through how to interpret this table. And you'll see that I've just put 4 indicators in there. And we can look at exclusive breastfeeding just because it's actually, let's look at skilled delivery because it's the second one down. And you can treat all of the numbers are essentially proportions. So what that first column shows you is that 41.3% of women reported that their last delivery was attended by skilled personnel at baseline. Okay, so we know that that's our starting point. 41% of these women were attending skilled delivery. Then if you look at the midline, you can see that in the control arm, that had gone up to 46%, while in the supply side arm, it had actually gone down to 38%. In the demand side arm, it was up to 47%, and in supply and demand, it was up to 48%. Then if you keep looking over, the next 3 columns show you the program impact, so the change relative to the control group in each of those study arms. And really importantly, the final 3 columns are the p-values. You can see that for skilled delivery, none of them are below our magic threshold of 0.05, so none of those changes are actually statistically significant. So what we can tell from this is that if we're talking about skilled delivery, there was no difference between baseline and midline. Okay, so that kind of seems like sad news from our project's perspective, right? And so we needed to figure out what's going on. So there are some other indicators that we collected data on that we could look at. Again, I've replicated that skilled delivery line at the top here. That's what we just looked at. But underneath that, you'll see referrals to delivery, accompaniment to delivery, and women who actually were transported to delivery. And if you look at the program impact columns, anything that's bolded there is statistically significant. You can see that even though there wasn't a change in skilled attendance at skilled delivery, more women were being referred to and accompanied to and even transported to delivery in the supply and demand side arms. And so this is promising because all of these are intermediate variables towards ultimately increasing skilled delivery. So we can say that although at midline we didn't see an increase in skilled delivery, we did see signs to suggest that we might get there in the end, and we hope that we'll see that in our endline data, which is something that we're going to look at, well, we're actually looking at right now. We don't have the results yet. So a few things to point out here, the importance of intermediate indicators in understanding the outcomes of interest, right? It's not enough for me to say, look, there's no difference in skilled delivery. We can say, okay, there's not, absolutely, but we see that some things are shifting and that could be helpful. The other thing that I think is really interesting from this table is that we do see that synergy that we'd hypothesized would exist between the supply and demand side interventions. So where in communities where both of those were implemented, in general, we see the largest positive impact from the interventions, which of course is intuitive, but you never quite know if it's going to play out like that or not. Okay. So what I wanted to know is, why are women not yet turning up to delivery? Why are more women being referred and more women being accompanied? And so these are the kinds of issues that we delved into in our qualitative data collection. And this is really where you can use qualitative data to really try and explain the numbers. And these were some of the topics that had come up that we thought might help explain why it was that people may not be turning up at delivery, even if they were being referred. And what came out, or I'll look at some of the findings in a minute, but these questions were informed by the findings from our baseline as to what we thought some of the barriers might be. But our idea was, let's use these women's stories as a way to be able to explain what's going on with the quantitative data. And so we found that some things were working really well. And you see here quotes from village committee members saying that health-seeking behavior for women to go to the health center delivery is happening now. It wasn't happening before. All pregnant women used to be delivered by the traditional birth attendant at home before the project, but that has changed now. Somebody's reporting that change is happening. And again, these are health workers saying deliveries, most of them are now delivering at the health facility unless they deliver on the way coming. That's interesting. So maybe there are those who are late to inform their husbands or in-laws or the traditional birth attendants. Those might be the ones delivering on the way, but otherwise they're all coming. So again, the health workers are saying people are coming. And then the final quote as well is essentially the same thing, saying make women understand that they should deliver in a health facility and they'll do it. So this does not reflect our data on uptake of skilled delivery, but it does reflect some of those intermediate indicators that we looked at. But we also wanted to figure out, well, what's not working? And so you see here some different perspectives, and you see some health workers who say there are some women here who'd rather die at home than come here during childbirth because there's no female midwife. Again, super interesting. A woman who had delivered recently said if your husband doesn't have a horse car or cannot hire one, you have to deliver in the village, even if you want to go to the health facility. The issue there is around transportation. Then there's somebody, this is a man in the community, talking about quality of care, and said the way I was received when I escorted my wife who was in labor was not the least satisfactory to me. Staff said they were having their breakfast and didn't have time for me. When my wife called for assistance, I found her in full labor and she delivered in my hands. So perhaps a disincentive for attending the health facility. And then from a health worker perspective, I'm saying that this is actually really challenging because we don't have the delivery beds, we don't have the facilities to do this. So the reason to look at these qualitative data is we've got some insight into people are saying there are aspects of this that are working really well, and we know that that people are saying that change is happening. But also, I think even more critical, especially the midline point, is looking at what's not working. If there's an issue that there's no female midwife, and culturally that's unacceptable, then you can put in place whatever incentives you want, but people are still unlikely to go and access care. So these data are really important, not just for understanding my data from my midline surveys, but this has to be used for course correction for the project. And that was sort of one of the primary aims, was to help them figure out how to improve the project for the remaining implementation period by learning from these data. And so the qualitative data provide all these insights you just can't get from the numbers alone. Okay, so I just wanted to take a step back before wrapping up, which is about the real-world challenges of doing this work. And this is partly about doing mixed methods work, and it's partly about just doing work in the real world. It's not like when you have a lab and you run a controlled experiment, you're the one doing the controlling, right? That to me seems like an incredible luxury. What I was doing was trying to fit around a government-implemented project. And so inevitably there are delays. And any delays that happened with the project meant that I had to delay what I was doing with the evaluation. And that had huge implications for staffing, like what the right moments are for recruiting people and all of those things. So that's just something you know is going to happen and you have to deal with. Politics is huge. The government of the Gambia was essentially overthrown halfway through this project. Everybody left. The president was ousted. As he left the country, he stole everything. So really there was no money then to do anything. New government had never been in government before. They had no idea what to do. So we went through all these kind of macro political changes that of course have an impact on what's happening on the ground. For months, there were literally no drugs in many of these health facilities. Again, like, incentivize as much as you like, but if there's no treatment available, people don't go to health services. And so from a study point of view, you have to document that. You have to understand why it is that you're doing all this stuff and still not seeing the results that you anticipate. And linked into that is this idea of contamination. When we started this work, we were literally the only project doing maternal and child nutrition and health in the Gambia. So it meant that any changes that we were seeing were a result of the work we were doing. When the new government came in, lots of new donors came in and started up this type of project all over the place. And so we suddenly found that in communities and facilities where we were working, there were other people working on the same issues. And that brings in problems of attribution in terms of any study. How did we know suddenly that any changes we were seeing were down to us? What if it was down to stuff that other people were doing in the same places? Again, we've been really conscientious in trying to document all of that, and we can't account for it statistically, but we can try and explain it in our write-ups. And then the final challenge that I want to mention is conflicting data, and this really is a challenge of mixed methods research particularly, and especially when, as I showed you, we tried to capture all of these different perspectives, both quantitatively and qualitatively. And what we found quite often was that everybody would say one thing, but then we'd look and see something totally different. Or we'd collect some quantitative data and we'd see something totally different. And then you come up with a challenge of how do you do that? Do you trust something that's written down more than what somebody says? You know, is this a problem with recall or is it a problem with record keeping? And you can't always tease that apart totally. And again, it's something you just have to be very transparent with in your research. And I'm not going to say I like it, but it feels like a bit of a mystery to be solved every time it happens. And I kind of get into detective mode and dig up as much detail as I can and try and tease things apart that way. But it's definitely something that comes up every time. It's like things just don't ever add up simply. You've got to try and figure out actually what's going on. So I do think there were some really strong features of this study design that helped with that. One was randomization. We know that there was no difference between our intervention and control samples at the beginning, and we checked that balance really carefully. We also, the triangulation across multiple data sources really helps with trying to create some sort of confidence in data. And like I just said, stuff conflicts and you're never going to iron it all out and make it all add up. But if you can look across various different sources, you may be able to get a sense of what it is that's going on. And so that's I find it incredibly helpful. And really, I think that for me, the ultimate strength of this is by combining the quantitative and qualitative methods. We had an impact evaluation, but with this embedded process evaluation that really allowed us to assess not just do these interventions work or not, but how do they work or not, and why do they work or not. And that's where the richest learning comes from implementation science. So for me, that's really what's critical about bringing these different types of methods together. So just to wrap things up, these studies can be like incredibly complex because everything's out of your control and you just have to learn to live with that and roll with it. It can be really difficult to isolate the effect of a given intervention, even in a context of randomization, if there's all this other work going on at the same time. But mixed methods really help try to figure out how and why things work or don't. But these kinds of studies are really, really expensive. And I say that because it means just that you have to be very rigorous about doing them and very serious about the questions that you're trying to answer. But I also want to say they're really, really fun. And I have a mountain of data over the last 5 years, and that feels like a really exciting treasure trove to kind of delve into. And really, there's an awful lot that we can say now about maternal and child nutrition and health in the Gambia on the basis of all these data that we've collected. So I'm going to stop there and let you guys ask any questions that you might have, and anyone can jump in.
Thank you, Dr. Ferguson, for sharing your work. We will definitely try to answer your questions. To submit a question, please type it into the Q&A box. Don't be shy. She is definitely here to answer those questions for you. Don't have many of them right now, but I would love to ask a quick question to you, Dr. Ferguson. How would students in our online program interested in working with you for any of your upcoming projects or initiatives get involved?
Yeah, that's a great question. I mean, the tricky thing about it is that I'm not in control of my timelines, and students need a kind of time-bound research experience because everybody wants to graduate, right? And so things are kind of last minute often. I think that the first thing students can do is email to indicate interest and also to indicate why they're interested. Like I believe in student involvement in faculty research, but I believe it has to be for a purpose. So obviously, like, extra hands to my research is always great, but what is it that the student is looking for in terms of developing new skills or experience? And that helps me try and find a match to an appropriate project, because some of my work is mixed methods and some of it's not. And so if somebody's particularly interested in this kind of approach, then that would help me narrow down, okay, well, what projects might be relevant. And so I think certainly, I'm not going to speak for all faculty, but for me, it's about knowing that students are interested in, but knowing why and what they want from it, and then us working up between us what that could look like, and how to find something that's going to work both for what I need in terms of support, but also for what a student wants to get out of it in terms of learning.
Okay, thank you so much for sharing. Our next question is, do you see more studies being conducted with the mixed methods approach?
An interesting question. I do. I think that there's increasing recognition of the value of mixed methods approaches. I think that one of the challenges is that quite a lot of our educational programs and actually like faculty positions and research positions are still siloed into quantitative and qualitative work. And so I think there are definitely impediments to people doing mixed methods work, because when you think about even tracks in the MPH, some of them are very quantitative, right? And they don't bring in qualitative methods at all. And it's fine, I'm not saying everybody should be doing mixed methods research, but I think in many ways it's more difficult to get a solid training across both quantitative and qualitative. And so you really have to be determined to make that happen. But I do think there's more and more of it, and it may be that's about more teamwork, working with people. So if you come more from one side than the other, reaching out to people who come from the other and figuring out how your work might fit together. So yes, I think it's increasing, and I think it could increase more.
Okay, thank you. Your next question is, how do you recommend students gain confidence handling so much complicated data like what you discussed? The student said it seems so overwhelming.
Yeah, great point. Baby steps. I think the way that I've done this with, I've had a bunch of students actually working on this data set with me. Some of them have only done qualitative work because that's what they've wanted to do. And everybody starts with really a bite-sized piece of the puzzle. I would never expect anyone to come in and get their head around how to manage all of these data and analyze them and bring them all together into something coherent. That's my job. But to have people either say, look, I only want to look at what health workers said, or I only want to look at qualitative data, or I've got a student right now working on quality of care and picking that as a component across different sources. So there's different ways of slicing and dicing the data into something that fits individual interests but is manageable. And so it could be about looking at 5 transcripts rather than 60, right? Or it could be about looking at 6 quantitative indicators and just seeing what we could say about that. You can make things as kind of small or as large as you want in this. And so if I've got postdocs working on these data, I'm going to throw bigger pieces at them. But if I've got people who are in an MPH program, it's going to be a much more manageable size that we carve out for people to work on. And then just one final thought, sorry. And ask questions. Like when you're new to stuff like this, of course it's overwhelming, but you have to ask questions to learn. So I think where you need confidence is to be able to do that, to be able to say, look, I've got no idea about this or that or any of this. Please walk me through this. Please walk me through this again. Please walk me through this in a different way so I can understand it. But I think that's where you've got to really put yourself out, is if things aren't clear, and of course they're not going to be at the beginning, you've just got to be persistent in asking questions in as many different ways as you need to get an answer that makes sense to you.
Absolutely. Thank you. Our next question is, what are possible ways to decrease expenses in methods?
Yeah, that's tricky. So the tricky thing with quantitative data collection is that if you want to be able to detect change in a statistically meaningful way, you need a relatively large sample size. And because we wanted to be able to look at effects between control arms, supply only, demand only, and supply and demand together arms, we needed a particularly large sample. We could have just said, look, we're going to stand solid and say, we think the way to do this is the supply and the demand side intervention together, and it's not even worth testing either of the others on their own, and we could have done a much smaller sample size. So that's one way of doing it, is to narrow down the number of different things that you're looking at, and that might mean you can decrease your sample size. And to be honest, it's the quantitative that's more expensive than the qualitative, because if you think about hiring a team of over 100, 3 times over, to go out around half the country to do this, that's really where a lot of the costs come in. The other way that we could have done it, and from a study perspective would have been absolutely fine, would have been to not do a midline evaluation. So we could have done a baseline and then just come back 5 years later and done an end line. The reason I didn't want to do that is because I really think that we learned useful things for informing the intervention at the midline point, and because nothing like this had ever been done in the Gambia before, we wanted to be able to learn those lessons and feed into implementation. If that's not a concern, and if you're really looking at this from a research perspective, we could have cut our costs by a third right there just by cutting out one round of data collection. So there's always compromises that you make, and it depends on what your priority learning objectives are, how you go about doing that. I mean, we could have done this on a much larger scale with a lot of sub-studies embedded, and from a research perspective, I'd have loved it, but it just wasn't practical from a budget perspective, and so we prioritized, here are the questions that the country wants answered, here are the questions that the World Bank wants answered, and then here are the questions that I managed to squeeze in there alongside that I thought were particularly interesting. And that's one of the wonderful things of being a PI, is you get to do that.
All right. Thank you so much for sharing that. Again, she is available to answer questions. Please don't be shy. You can type your question in the Q&A box, and we will definitely answer them for you. I believe Dr. Kumar had a question for you at this time as well. Dr. Kumar?
Yes, thank you, Kiana. Thank you, Dr. Ferguson. That was really interesting. I wanted to ask, what would you say is the most rewarding part of your work?
That's a great question. I think the most rewarding part is seeing change happen. I've been going to the Gambia now multiple times a year for about 5 years, and things really have changed visibly in that time in a lot of the facilities where this project is working, and in a lot of the communities where this project is working. So there's something exciting about that, because you realize that this has an impact on people's lives, and that's ultimately why we're doing it, is that we want to be improving people's lived experiences. And when you get to be involved over this period of time, you get to see things like that. And we've also been able to use our findings to feed into not only government policy, which obviously affects the 2 million people in the Gambia, but also donor policies. So we've been shaping World Bank prioritization in other sectors, like some of their infrastructure development projects now targeted health facilities, because we pointed out that actually none of them had electricity, and this made service delivery hard. USAID and actually the Global Fund as well have also asked us for certain bits of data to inform how they prioritize their giving in the country. And so it's, to me, I mean, obviously as a researcher, being able to create data that are relevant and that can have immediate impact in terms of what's happening at a country at the macro level of policy and donor giving, and at the very individual level of ultimately we know that this is changing people's lives. I think that's what gets me excited about the work.
Wonderful. Thank you so much for sharing that. We have one more question for you, Dr. Ferguson. In general, do students who apply for grants to conduct mixed methods studies get funding versus those who choose quantitative versus qualitative methods only?
That's a really hard question to answer in the abstract, because it depends very much on where the funding is coming from. Different funders have different interests, and I think it's really important when figuring out your research that there's a balance. You have to start, in my mind, with a research question that's relevant and the appropriate methods that go with it. Right? That's got to be your starting point. And then you look for potential funders who are interested in those methods. And if you can't find them, and you have to start making compromises about your methods because you want to do mixed methods, but you can't find anyone who's going to fund that, then you need to go back and say, well, if I did do only a quantitative study on this, can I still answer my research question sufficiently from my perspective? Or if I only do qualitative, is that sufficient? I think that there's a very careful line that you have to tread between doing meaningful work and falling into donor priorities because that's what you get money for. And I get from a practical perspective that we all need funding to do our research. But I think there's something really important about maintaining the integrity of what it is that you're trying to do, and fighting for it with donors. I think there's a lot of donor education to be done about why mixed methods are important. So I don't think mixed methods makes it impossible to get stuff funded. I just think, and again, it depends on what the donor's interests are, but if somebody's coming to me, what I want to know is this study solid? Are these the appropriate methods to answer the research question? And if that's purely quantitative, fine. If it's mixed methods, fine. So it's really about making the argument for why it is that you've chosen a particular set of methods to answer your research question of interest.
Thank you. All right, if we don't have any more questions, I definitely want to thank you, Dr. Ferguson, for sharing with us today. Thank you to our speakers, Dr. Kumar, William Jardale, and to everyone who participated today. If you have any questions regarding the enrollment process or you feel like you're ready to apply, you can definitely reach out to one of our admissions advisors. The contact information is on the screen right now. Again, a copy of this recording and slide presentation will be available shortly after. This concludes today's webinar. Thank you again for joining us, and everyone have a wonderful, wonderful rest of the day. Thank you.